The next several neuro lectures are going to look at various neurological disorders. The first one that we're going to cover is cerebrovascular accident, also known as stroke. After that, we'll go through the other ones that are listed here on the slide. When we look at patients that have had a cerebrovascular accident or a stroke, it is the third leading cause of death in the United States, and someone has a stroke about every 45 seconds in the U.S. It leaves about 30% of the victims with physical and mental disabilities that will require assistance with their ADLs. So that means that there are about 1 million people out there that have post-stroke disabilities. And as we all know, since we've taken care of patients that have had strokes, this can cause psychological, physical, and economic difficulties. The direct and indirect costs of management of these patients is approximately $57 billion per year. A stroke can be defined as a sudden decrease of blood flow to a localized area of the brain. Two different types of strokes are listed here. The most common one is an ischemic stroke. About 85% of all patients will suffer this type of a stroke, where there is an occlusion of an artery in the brain from either an embolus or from a thrombus. Hemorrhagic stroke is what about 15% of all patients will suffer from that have had a stroke, and this is where there's actual bleeding into the cerebral tissue. The case study that we have for CVA is going to be a 65-year-old female who's overweight. Past history includes a fem-pop bypass. She smokes 2 packs per day for the past 35 years, so she has a 70-year pack year history. She drinks 1 to 2 drinks per day, has been on estrogen for approximately 15 years, and there is a family history of hypertension, diabetes, type 2, cancer, and also strokes run in the family. The assessment data for this patient include that she complained of a headache about 24 hours ago that was relieved with aspirin. Several hours later, she had slurred speech, numbness in the fingers of the right hand, and also numbness on the right side of the tongue and the lips. She now presents in the ER with a left-sided headache. She's alert but drowsy. She has expressive aphasia. Left upper extremities are noted to have normal hand grasp. Her smile is asymmetrical, and she has right facial weakness. Blood pressure is quite elevated at 230/110. Pulse is 90, respiration 16. Temp is normal, and NeuroCheck notes that pupils are pearla. She has some diagnostic tests done, and those show that chest x-ray, EKG, and labs all came back normal. However, the CT scan did show an increased density on the left side of the brain, which would indicate an infarction in this area. So if we look at the type of CVA that this patient might have had and why, we want to break down those 2 types that we talked about in an earlier slide. Like we said, probably 85% of all strokes are caused by a clot in an artery that then blocks off blood supply to the brain. This would be considered thrombosis with an ischemic event, and the causes that are listed there for the most common things that can cause this type of a disorder. Atherosclerosis, hypertension, diabetes are all common causes. The second time listed there is an embolic CVA. The onset of this typically is fast. One common cause is a patient that is in atrial fibrillation and then throws a clot from the heart, which travels up to the brain. Or it could be that the patient has the carotid or cerebral arteries that become occluded from a traveling clot. So this constitutes about 15% of all strokes that we see with patients. Patients may also have strokes from a subarachnoid hemorrhage, where there's blood from a vessel that leaks into the circle of Willis, and then that blood leaks into the subarachnoid space. Or patients may also have an intracerebral hemorrhage, where there's an actual hemorrhage within the brain tissue itself. Common causes of this could be an aneurysm, and the symptoms that the patient has relate to the area of the brain where the clot forms. So the patient may have symptoms of vomiting, headaches, seizures, hemiplegias, loss of consciousness, which can lead to increased intracranial pressure, which can lead to comatose state, and then death. So how is it determined which type of CVA that a patient does have? Well, typically what's done is the patient has a CT scan and an MRI done, and then also a lumbar puncture. The lumbar puncture can confirm a subarachnoid hemorrhage because there will be a increased pressure, and there will also be blood that will be noted in the CSF. This is only done if there's no danger of increased intracranial pressure with the patient, because that can lead to herniation of the brainstem. So when they do a lumbar puncture, remember the patient needs to be in a rounded position, as you see here, where the spine needs to be rounded. So the patient almost needs to be brought into a fetal position with the knees up to the chest to round out the spine, so that the physician is able to access that lumbar vertebrae space in order to do the procedure. Risk factors for stroke include the modifiable risk factors such as lifestyle, weight, smoking, intake of alcohol, hypertension, oral contraceptives, elevated cholesterol levels, patients with perhaps a history of sleep apnea, substance abuse, recent viral or bacterial infections, and also complications of pregnancy and childbirth. Non-modifiable risk factors would include family history, the age of the patient, sex of the patient. It's 2 times higher in women than men. African American, so it's race, gender specific. There's a higher incidence in African American than Caucasian patients. A higher history with patients who do have diabetes, patients who've had a recent TIA, patients in menopause, history of migraines, history of lupus, clotting disorders, or sickle cell disease. So with our particular case study that we have for this, the patient's risk factors were the elevated blood pressure, the fact that she had had a fempop bypass a year ago, she's a smoker, she's drinks alcoholic beverages on a daily basis, she's on estrogen, the fact that she is a woman puts her at higher risk, and the fact that there's a strong family history of strokes also. The typical warning signs that are seen with a stroke is a sudden weakness in the arm, the hand, or the leg. The patient may complain of a loss of feeling in a side of a face or the body, difficulty walking, the patient may be dizzy, and have difficulty understanding spoken speech, and complains of severe headaches. So those are the typical symptoms that we see. There was actually an ER episode that's on Thursday nights about a year ago of a patient that was rather young that was brought in having a stroke in progress, and it was very interesting to see the patient was unable to express herself, had the typical symptoms of stroke, and part of the show was actually from the perspective of being a patient and have that happen to you. So it was a great episode that depicted a stroke. The patient may question the nurse about that numbness on the right side of the mouth, the tongue, the fingers, and the hand. So the best response from the nurse would actually be D. These symptoms the patient has may be temporary, and it may be due to the brain not getting enough oxygen or glucose. We don't necessarily know that when her blood pressure is controlled that those signs and symptoms are going to be completely gone. So we really can't give that response to the patient, so C would be wrong. When we look at stages in stroke development, we talk about TIAs, which I'm sure you've all heard of. A transischemic attack looks at the patient has symptoms that usually resolve without any residual effects. So this episode can last for seconds, minutes, or hours. Probably the average length that it lasts is about 10 minutes and resolves within an hour. The best way to look at TIAs is that they are warning signs of an impending ischemic problem. And as a matter of fact, research has noted that about patients who've had a TIA are 9 times more likely to have a stroke than a person who has not had a TIA. So typically they can be caused from atherosclerosis or a small emboli, and the symptoms will vary with the site of the pathology. The symptoms they typically have are numbness or weakness in the legs, hand, or forearm, or the corner of the mouth. They may have aphasia or blurred vision. So patients that have had these will need a workup done, and they may be a candidate for an endarterectomy or angioplasty. A reversible ischemic neurodeficit is similar to a TIA, but it lasts longer. Typically, this will last longer than 24 hours and usually resolves within 1 to 3 weeks. So sometimes you'll hear this referred to as a small stroke. A stroke in evolution starts as a TIA and then it worsens over a couple of days. So this is actually a progressive stroke. The patient usually comes to the hospital when the symptoms continue to get worse and they don't resolve, this can develop over hours to days and can lead to infarction. A completed stroke is where the deficits are seen in the patient following the stroke. Those deficits may not be apparent for up to 72 hours due to secondary injuries of the brain and cerebral edema. About 60% of thrombotic strokes occur during sleep, so the full effect won't be evident, the full effect will be evident when the patient awakens. So this also will be a factor that determines what type of a treatment the patient's going to get for the stroke, depending on when the start of the stroke actually occurred. About 60% of thrombotic strokes will occur during sleep, like I said, and will result in neurodeficits and require rehabilitation to get that patient to get functioning back of motor response and those types of things. So how do we treat the patient that's had a stroke? Well, for those patients that have had an ischemic type of a stroke, typically they're going to be put on some sort of a thrombolytic agent, which will actually break apart the clot. So tissue plasminogen activator, or TPA, is a common product that's used. That's also known as Activase. You may hear urokinase also being used. What this does is it actually digests the fibrin threads and it lyses the clot. In other words, it breaks it apart. The thing that is very imperative with this particular drug is that it needs to be given within a 3-hour window treatment from the patient's first onset of stroke symptoms. If they miss this 3-hour window of time, then the patient will have a cerebral angiograph done where a catheter is placed in the carotid artery proximal to the clot and advanced to the site of the clot. At that point, they can give TPA very slowly directly to the site. Probably, according to some data I was able to find, only about 5% of clients that get to the ER actually come within that 3-hour window of time to be able to get the TPA. So there are a lot of eligibility criteria in order to be given this. So look at your speaker notes to look at what some of the eligibility criteria are for this particular thing. Anticoagulant therapy is also going to be something used for the patient with an ischemic stroke. We would never use this for a patient that had had a hemorrhagic stroke, obviously. So heparin therapy with this particular treatment method is going to be contraindicated for any patient that has a history of bleeds, such as GI bleeding, or has an allergy to heparin, or has some sort of history of some bleeding disorder and that type of a thing. So unfortunately, heparin and Lovenox have not been as effective as the sole treatment in an acute stroke. So if that patient is a candidate for TPA, that's a much better route to go as far as trying to reverse the effects of what's caused with the stroke. The ER episode that I mentioned earlier in the lecture, with that particular patient, she was probably, I would say, in her late 30s, early 40s, and what they did is they rushed her for an emergency angiogram and gave her TPA at the site of the clot. And actually, she did have all symptoms then reversed because the clot was able to be lysed that way. So just remember, you have that 3-hour window of time, and that's the crucial thing when we're talking about TPA. Whereas with heparin, you would not have to follow that 3-hour window of time criteria. So patients that are put on anticoagulants such as heparin, remember, just a review, assess the PTT, check stool and urine for blood, check skin for bleeding and petechiae, check gums for bleeding, and anytime that patient complains of headache, joint pain, that type of a thing, it should be reported. and that patient is typically started on Coumadin almost at the same time as the heparin is started, because remember, Coumadin has about a 4 to 5 day window of time to get it up to therapeutic values. And remember, Coumadin would be monitored, the dose, with the PT level and the INR level. Other meds patients might be put on would be an anticoagulant such as aspirin. We're talking about long-term use here. Also, patients may be put on antiplatelet meds such as Plavix. Persantine and Ticlid are a couple other meds that are commonly used for patients. And Agrinox is actually a pretty new drug on the market that was just approved by FDA, and this actually combines aspirin and Persantine. So this is a drug patients may also be put on. And then ACE inhibitors, they may be using those just such as Captopril would be an example of one. They are very cardioprotective, and so they may reduce the risk of CVAs and MIs. The patient that has had a left-sided CVA, in other words, if there's a stroke or a hemorrhagic or a thrombus event in the left side of the brain, it will typically cause slow, cautious behavior, speech and language deficits, because remember that 95% of the population has the left hemisphere dominant for the language centers that we talked about earlier, the Broca's and the Wernicke's areas. They will show the right-sided hemiplegia or hemiparesis. They will have something called right homonymous hemaniopsia, and we're going to talk about that on a later slide. And we just touched on the fact that they would have writing and speech difficulties due to the fact that Broca and Wernicke's areas would be affected by the infarction in the stroke area. Patients that have had a right-sided stroke will have more of the sensory perceptual deficits, left-sided weakness. They typically will be very impulsive, lack insight, because remember, your right side of your brain is your sensory, perceptual, visual, spatial processing center. So patients may also have problems with being aware of their body and space and that type of a thing because that area has been affected. They may have left hemaniopathy. Let me try that again. Left homonymous hemaniopsia. So this is a slide that talks about what that is. If you look at the third reading there in the middle there where it talks about left HH, it's showing where there's a lesion of the optic tract that interrupts the fibers originating on the same side of both eyes. So visual loss in the eyes is therefore similar and will involve half of each field. So patients that have had a right-sided stroke will have left-sided HH. In other words, if you look at that number 3 picture there, the left half of each visual field is completely gone. They're showing you that it's blacked out. So you can imagine if you set a plate of food in front of a person, they're only going to see the right half of the plate. They're not going to see food on the left. If you try to assist them from the left, they're not going to see you until you stand directly in front of them. So these would be things that you would need to keep in mind as you're trying to help take care of patients who've had these visual defects with strokes. As far as patients who have the aphasia difficulties after having a stroke, we've touched on this earlier in the neuro lecture, but patients who've had Broca's aphasia, of course, are going to have those expressive problems. So picture boards are going to be helpful. Try to anticipate their needs. And these are the patients, remember, that stutter and that they get very angry because they know what they want to say, but it just doesn't come out. So give them enough time to answer your questions. Patients who've had a stroke that's affected Wernicke's area, remember that's the area responsible for comprehension of speech and written words. So these patients, remember, may speak fluently, but they just don't understand what's being said to them, or they may use jargon and word substitution and things like that. So give them only one command at a time, use gestures, speak slowly, and try and keep distractions down for these patients. These would be some appropriate calls for nursing for patients that have had a stroke, so you can certainly look through those yourself. Just a reminder that swallowing defects do occur in about 45% of all patients who've had a stroke. So typically these patients will have a swallow study done before they're allowed on solid foods and that type of a thing. Some complications that we try to prevent with patients who've had a stroke include preventing increased ICP. They're at very high risk for this the first 72 hours after the onset of their stroke. And we discussed nursing responses for ICP in an earlier neuro lecture, so you can review those. Also, another complication we try to prevent is extreme hypertension. The goal is to keep the systolic blood pressure over 100 but under 150, and to keep that mean arterial pressure when we look at that between 700 and 100. There's a typo in there that should say 70 to 100. Sorry about that. So continued assessments for patients are going to be frequent neurochecks, the hazards of immobility. They're at risk for skin breakdown, so we need to turn and reposition them every 2 hours, and those types of things. We already talked a little bit on the problems that would be with altered nutrition. Nursing responses for patients with altered nutrition. We talked about the swallow study already. The other thing that would be important is to make sure when that patient does begin to take foods, mechanical soft would be most appropriate early on. Thicken the fluids with Thicket. We get occupational therapy involved to use adaptive devices. Physical therapy would also be working with these patients. And be real careful, these patients watch for pouching of the food because they're swallows. They have a difficult time swallowing, so place food in the unaffected side of the cheek. That's most helpful for them. Once they have stabilized, usually after about 48 to 72 hours, then they can start with some physical therapy. And these patients essentially will need to relearn how to walk and talk all over again. And the way that that's possible is because repetition of activity actually forms new pathways in the brain so that the patient can relearn to do these things all over again. So remember, in positioning, the muscles tend to adduct and rotate internally because the flexor muscles take over. So this can lead to contractions. So the patient may need splints, high-top tennis shoes, and those types of things to prevent foot drop. And we talked about earlier that skin breakdown is a risk. For bladder and bowel control, we get these patients on a bladder regimen. Once they get off the Foley, then we usually try to get them on some sort of a regimen to get a voiding schedule back for them, increase fluids. And for a bowel regimen, we follow the things listed on your slide there. The patients are typically very tearful, especially depending on which side of the stroke the brain was affected by. So those patients with left CVAs will be more anxious and cautioned. And remember, depression is seen in about 50% of patients that have had strokes. So they may also need to be put on antidepressants. They will tire very easily, and getting the family and the patient into a support group is very helpful. So we may use complementary therapies on them, and that may help, such as music therapy and different things like that. So the NCLEX question that goes with strokes is a priority assessment in the first 24 hours after CVA is which of the following. So remember the risk of increased intracranial pressure. So one of the top things that would be our priority is try to make sure that patient isn't developing that. So checking pupil size and response would be the correct answer here. For the NCLEX question for the patient with expressive aphasia, which action is most helpful? And the correct answer here, use short sentences. Remember, with the patient with Broca's area affected, the problem that they have is with formulation of words and expressing them and those types of things. This next lecture is going to be a very short one. When we look at patients with cerebral aneurysm, the care for these patients and the signs and symptoms that you see are very similar to a stroke patient. So that's why we're not going to get into a lot of detail on cerebral aneurysms. They are defined as a dilation and weakness of the cerebral artery wall. What happens is there's a rupture that results in hemorrhagic stroke, and this can cause congenital defects. causes can be from congenital defects, atherosclerosis, hypertension, or any type of trauma to the head, and that type of a thing. Advanced age is also another factor. So calls for nursing and interventions are going to be very similar as what we discussed with the patient that's had a CVA or a stroke. Probably the thing that's different between these two is that these patients many times will develop what we call a vasospasm, and this is a sudden, dangerous, and transient constriction of the cerebral artery, and it often occurs after a cerebral hemorrhage from an aneurysm rupture. So blood flow to the distal areas of the brain are then diminished, and this can lead to cerebral ischemia and infarction and further neurological dysfunction. So typically medications that are used to help treat this vasospasm include calcium channel blockers such as Nimotop, and also it usually takes about 21 consecutive days this patient takes for this particular med. Patients that have vasospasm may also have seizure activity, so they may be on anticonvulsants for that type of a thing. Treatment for aneurysms is going to include a craniotomy with a clipping, stents being put in, and balloon remodeling. So you can read your textbook to find out more information on these types of things. The goal in the treatment of aneurysm is to prevent a rupture of that artery and to isolate the vessel to prevent further bleeding. So the way that this is done typically is through clipping. So this is showing you how a clip is actually placed in that artery so that if that berry aneurysm would burst, it would not lead to bleeding then from the meningeal artery where the patient would bleed out in the brain.